Good morning, everyone. Here we are this morning at another great breakout session for the Ed Forum in St. Louis. I'm Shirley Gantz, and we're happy in this session to hear from Dr. Shayna Sarosiek. She's assistant professor at Harvard Medical School and a physician in the Bing Center for Waldenstrom macroglobulinemia at Dana-Farber Cancer Institute. She's attended medical school at the University of Miami in Miami, Florida, and completed her residency training as well as an amyloidosis fellowship and hematology and oncology fellowship at Boston University and Boston Medical Center. Dr. Sarosiek spends her clinical time dedicated to the care of patients with Waldenstrom's, IgM-related disorders, and AL amyloidosis. Her research focuses on advancement of novel therapies for these patients with a focus on amyloidosis and immunotherapies. So today she's going to talk about the interaction between patients and physicians and how we can all get more comfortable with the types of treatments and how we go about really getting to know our doctors, get along with them, and share the decision making. Dr. Sarosiek.
Adjust this. Hopefully you all can hear me. Oh, no need to clap. Okay, perfect. So thank you for that kind introduction. I'm very happy to be here today. And I just want to say I have a few slides here just basically introducing this concept of patient-doctor shared decision-making. But I really would love for this to be more of a conversation. I think we all have the opportunity to learn, both as physicians and as patients, how we can best serve each other. And luckily for our patients with Waldenstrom's, often this is a years and decades long relationship. And so I think doing everything we can to really maximize that and allow us to give you the best care is really important. So I would love to hear any input or questions that you all have along the way. So thank you for having me here today. So I was asked to talk about patient-doctor shared decision-making. And so I have a couple of slides just at the beginning, saying exactly what is shared decision-making. This is a topic that actually there have been many manuscripts published on this and a topic of ongoing research. So there are some, technical definitions that surround this topic of shared decision-making. So essentially what this is that when clinicians and patients work together to make decisions, and they select treatment based on evaluation of risks and benefits of treatment, but also based on patient preferences and really valuing the patient preferences and valuing the decision-making together. So why is this important to have shared decision-making? There are a lot of data out there that tell us that having shared decision-making leads to improved quality of care for patients, improved patient satisfaction, and also improved adherence to therapy. So all three of those things, as you can imagine, lead to a much better life for our patients and also much more effective therapies as patients are able to adhere to their treatment. Also, because of having those improved outcomes is important, but also it's very important because in the United States, it's really the patient's rights to be informed and participate in their health care is really, I think, something that we value in the U.S. and other countries do as well, but that's very important, I think, that shared decision-making is included as part of our care. So why is this important in Waldenstrom's to have shared decision-making? One, Waldenstrom's is a rare disease. I think that as a clinician, I see a lot of Waldenstrom's patients, but I can never know everything there is about this disease. It's rare. We don't have a lot of excellent data compared to some other diseases that are much more common. And so it's important for me to be constantly learning and other physicians to be learning, and also for patients. Again, because it's a rare disease, you might not always have access to all the information you need to know about the disease. I think it's really important, although I have the luxury of seeing a lot of patients with Waldenstrom's, I think most providers in the U.S., most oncologists and hematologists, don't get to see this disease very often because it is rare. And so again, being open to hearing what your patients say and to constantly being open to learning is really important because it is such a rare disease. And I think, as I have mentioned already, that both of us, patients and providers, can continue to learn throughout the duration of the relationship. It's also, I think, very important to have shared decision-making in Waldenstrom's because we have many excellent treatment options. We have the luxury in Waldenstrom's of, often, in most cases, being able to talk to patients about multiple different options and being able to really prioritize what the patient would like for their disease. And so I think instead of, as a physician, just walking into a room and saying, this is your option, or this is the treatment we're choosing, and this is what you're going to do, I think because we have a lot of different treatment options, it's important to really discuss risks and benefits, quality of life changes, potential symptoms with each therapy. And in many cases, because we have a lot of treatment options, there's not always a correct answer in terms of which therapy to use. I think, unfortunately, I did not arrive for the earlier days in time to hear, but I think I heard that yesterday there was a session talking about BTK inhibitors versus chemoimmunotherapy. And what I heard after talking with people last night when I arrived about that debate is there's not a correct answer to that question. And so that was one of the examples that I had put up here, is that for many patients, rituximab bendamustine might be the right answer. For other patients, a BTK inhibitor might be the right answer. And it really is about figuring out what works best for that patient. And not just, so this is an example in terms of therapy, which therapy to use when a patient needs treatment. But this concept of shared decision-making is also important in terms of deciding when a patient needs therapy. So we have guidelines for Waldenstrom's that say for hemoglobin less than or equal to 10, that would be an indication to start treatment. But I have some patients with a hemoglobin of 10.5 or 11, and they have extreme fatigue, and they need therapy or want to have therapy. And then I have patients with a hemoglobin of 9 and 9.5. They feel fantastic, as if absolutely nothing is happening, and they don't want therapy. And so this is another example of a time when a patient and a physician really need to sit down and talk about risks and benefits of treatment, when it's the right time to start, and make a plan for continued follow-up. And then I think an important concept for a lot of patients, many of whom are probably in Shirley's session right now talking about neuropathy, but this is a big obstacle in Waldenstrom's is IgM-related neuropathy. I think it's something we're learning about, a lot of patients are dealing with, but we don't have an exact answer about when to start treatment when patients have neuropathy. Do we start it very early? Do we start it later? It's a complex topic that really requires a lot of ongoing discussion. And then, so another reason for shared decision-making in Waldenstrom's is in many cases there's no correct answer to which therapy should start and when to use the therapy, as we just talked about. But often therapy needs to be tailored to each individual. For example, if a patient doesn't want to take a lifelong therapy, if a patient wants to avoid toxicity of chemotherapy. This is not going forward exactly as I expected, but another thing is that, as you all know, with treatment for Waldenstrom's, the goal in the treatment is to really allow patients to have an excellent quality of life as they move forward with the disease. We all know, unfortunately, we don't have a cure at this time for Waldenstrom's, and so we really want to allow patients to live their best life with their Waldenstrom's. And so that is, in my opinion, that's one of the paramount goals of Waldenstrom's treatment, is to be able to do that. I think it's really important to have shared decision-making with the patient and the provider, because you need to know what your patient's goals are. And so, in my opinion, that's something I work hard to do, is to understand my patients and their priorities, because that's a goal of treatment in my patient is, do they want to be able to do certain activities, or how do they want to feel? And then, so now I think, now that I've just talked a little bit about what is the purpose of shared decision-making and why it's important in Waldenstrom's, I think we can talk a little bit about the patient role in shared decision-making, and then also talk about the physician role in shared decision-making. And I have to say, this is just information, a lot of it from research on this topic, but certainly you all are the patient, and I would love to hear more from you if you feel like there are other things that we should be considering in this, or that you think it's really important. But from the studies that have been done and the literature that's available, shared decision-making as the patient in that relationship, it's important to educate yourself. And this is something I don't really need to be saying to all of you, because clearly that's what you're doing. But it's a really important part of care, not just in Waldenstrom's, but other diseases, for patients to really know what is their disease, what their options are, and really seeking out opportunities to educate yourself. Proactively seeking information, not just taking in information that's offered to you, but also looking for additional information and additional opportunities to learn. And certainly finding high quality data, I think, is a patient's role. I think it's sometimes hard to be able to do that. We all have access to a huge amount of information on the internet and other places, and sometimes that data is not necessarily high quality, and sometimes can be, I think, anxiety-provoking information, but really being able to figure out where you can find that high-quality data. And of course, the IWMF is really a key place for our patients with Waldenstrom's to find high-quality, patient-centered education. There are other sources too, as many of you know, LLS and LRF and other foundations that provide high-quality, patient-centered information. But that's really important to make sure that the information that you're getting is information that will be helpful and correct for you. And then I think a really important part of the patient's role is involving family and friends and other support that you need. Often, making decisions about your care really affects a lot of people in your life, so that's a really important part of this process. And then I think this can sometimes, be challenging maybe for some people. I certainly have heard stories of this from some of my patients, is being able to collaborate and discuss with your healthcare provider. I think that's not always easy to do with some providers, and maybe not always easy to do as the patient, to really say, I want to take time to discuss this. I want you to tell me more about this. But I think it is important as your role of the patient to feel free to ask more questions, feel free to ask for more information, to take time to think about your options, and really make it an open relationship with your provider. And the thought of taking time to think through options, luckily with Waldenstrom's, that typically is something that we can do. This is a very slow-growing disease, and many of my patients, even when we get to the point where they think and feel, and I think and feel that they need therapy, we often have time to say, okay, these are your options. Let's walk through them a little bit. You go home, take some time, read about it, learn more about it, turn to your support group, your family, your friends, think this through, and then come back and we'll talk about it again. So I think it's important, when possible, to, as a patient, for you to advocate for yourself, ask those questions, and find a provider who you feel comfortable doing that with. Certainly, sometimes I think, your access to providers might be limited, but if you can't do that with a provider, then finding other support, like support groups and things like that, to help you think through these options, I think is really important. And as the vast majority of my patients do, I think as you go through treatment, monitoring your results and asking questions to understand them is really important. I try as a physician, I'm sure I'm not always successful, but I really try to help my patients understand results. They're always, you get what you think is one blood test, comes back with 35 results, and it's hard to really understand those. So as your role as in your role as the patient, it's important to kind of sort through those, and even, you don't have to understand them all, but understand which are the key results that are most important for you to think about, and then ask questions if you don't understand. And again, those questions, hopefully you would feel comfortable asking your physician about those things, but I think also, using your backup support, your support group and family and friends, to ask those questions if you don't understand. And then I think it's really important also in Waldenstrom's to be open to consultations with other specialists. There are significant complications that can come along with Waldenstrom's, so patients often can have some heart issues or abnormal heart rhythms related to oral therapies like BTK inhibitors, so seeking out a cardiologist. Certainly the neuropathy related with Waldenstrom's patients may need a neurologist. We definitely have patients with kidney involvement. And then additional supportive care teams like nutrition is important. Social work and psychiatry or psychology, I think, is also very important. We like to offer that to our patients whenever they need it because having Waldenstrom's is not an easy thing to deal with. And being open to additional support and additional input from other specialists, I think, is always important. So I think you all probably know these things that I'm saying to you, and you're all incredible experts at your patient role in shared decision making. But these are just kind of the things that the data has shown is important for patients to do. So really seeking out answers, educating yourself, collaborating with your healthcare provider, and being open to always learning something new from other specialists or from your providers. Certainly, if anyone has thoughts or questions about that, you can interrupt and give me your thoughts. But as a physician, I think we certainly have a very important role that we need to take on also in shared decision making. So I think it's the provider's role to be someone who will partner with you and hopefully be someone that you can trust and respect. I think we as providers need to realize that our patients are our partners in this journey and need to be available to you. I think hopefully, oh, yes, please, question.
Well, just further to what you're stating, it sounds like you're really open and you actually want to partner. Maybe not all of our doctors are that open to partners. So how do you suggest to, jump across that divide? I don't know, because maybe ego is involved. Like you don't need a second opinion because I'm telling you what it is.
Mm-hmm. Yeah.
Like that kind. Not all of us have wonderful doctors like you, right? So.
Yeah, I think that is challenging. I think it is probably quite challenging. So I see a lot of patients that have local oncologists and then just come to me for a second opinion. I will say that then I communicate with the local doctor quite frequently. I will say that in the vast majority of cases, the patients have physicians that are more than open to hearing additional input and learning. There are rare cases, I'm sad to say, that occasionally I reach out to the provider and they want absolutely nothing to do with another opinion. Honestly, I think that's, from my perspective as a physician, not a great way to practice medicine. None of us are perfect, and we all need to be open to learning constantly. I think having a provider like that, if there are other options, I think that's rare that happens, but if there are other options, really, I think you can find the best healthcare, even if it's someone that, sees a lot more patients. This is my opinion as a physician and as a patient sometimes. If you can find a provider that, even if they don't see quite as many patients similar to you, but they are open to learning and hearing advice from other people and continuing to collaborate with you, I think that's sometimes more important than just having, someone who's not going to value your care. So when that's an option, I think, potentially switching to someone who's more open to working with you is important. I think often, though, like I said, the vast majority of providers are, when I call them, they're more than happy to hear and to learn a little bit more because they know this is a rare disease. And so I think as a patient, I think you have to be willing to ask your questions and ask for a few more minutes. And, everyone in the world is pressed for time constantly. But as a physician, that's kind of our role to be available for patients. So I think, if you say, I'm sorry, I just need a couple more minutes, I want to ask about these things, I think maybe your physician can't get to every single question you have on that day. So you could ask, I have a list of questions. Is it better if I ask them now, or can I ask one or two now and a few more at the next visit? Or is it easier for you if I send a quick message? Because I, email with patients or send messages in the portal. Would that make it easier for you? And so maybe asking your physician, what's the best way for me to communicate with you, or easiest, because I know you might be busy today, or something like that might make it a little bit easier for the physician to be willing to answer your questions. Or, because sometimes in the middle of a busy clinic it is tough, and I might say, oh yeah, send me an email tonight, and I'd be happy to, answer that. So.
What do you suggest about, because when I was first diagnosed, I'm on the Facebook group and everybody's saying make sure you go to like a specialist, and I'm in an area, like I don't know who a specialist is, it's not listed. So then I was, asking the oncologist, I'm like, how many patients have you treated with WM? Thinking that was, what I was kind of supposed to do, and I could see that she was taken aback.
Mm-hmm.
Didn't really want to do that, but I know she's also somebody who was open and wanted to learn. And then she said, look, I know people at Dana-Farber, and if I need to, I will consult with them.
Mm-hmm.
So that openness to the learning that you brought up sort of was there. But I'm just wondering, was there a better way I could have, said, like, how many patients do you actually deal with WM?
Mm-hmm.
Without it being awkward.
Right. Yeah, I think sometimes people might get a little defensive if they hear that question. I think it's totally appropriate to ask, though. If I go to a surgeon and I'm going to have surgery, I feel completely comfortable saying, have you done this surgery before? I mean, I think it's an okay question to ask, even if the physician might be a little bit defensive at first. I think, if you ask the question and they say, I've never, or I only have a few patients, and I think the follow-up that you mentioned is important to say, like, if I see another person in consults, or, do you know anyone else that sees Waldenstrom's, if something complicated comes up that you're willing to work with? I think it's an appropriate follow-up question, because I think, like I said, I have some physicians I work with around the country that really only have 1 or 2 Waldenstrom's patients, but I speak with them very frequently, and I feel like they're doing an incredible job taking care of their patients. Once in a while, like I said, once in a while, and I hate saying this, I do talk with someone, and and they say, oh, I see so many Waldenstrom's patients, but they have they do not want to hear any other opinion. And I think that worries me more than a willing and open physician who sees 1 or 2 Waldenstrom's patients, but is happy to talk. And, I see a lot of Waldenstrom's patients, but I am happy to hear input from anyone about what else I can learn and how I can better help my patients. So I think that, in my opinion, is an okay question to ask. And but the follow-up is just, are they willing to continue to talk with you and learn? So, yes. Sure, anytime. Go for it.
So in my support group, the question comes up, when to go for a second opinion. Do you think it's better at the very beginning? I've had other patients say, well, I'm going to wait till I need treatment, then I'll go get a second opinion.
Mm-hmm.
When do you think it's best? Is it the very beginning, or?
Yeah, good question. And it probably, I think, varies. Honestly, if possible, I think, and if you have the resources and the ability to do so, I often think that going initially, just to get a better idea of your disease and of the things to be watching out for and that sort of thing, I think actually in obtaining all of the initial information on your disease, I think that's helpful if you can do that initially. Even if you can't continue to follow up with the specialist or the extra opinion during the watch and wait period, where that might be months or years, but just to learn as much as you can up front, I do think that's helpful. I mean, often, I'll see patients that, we legitimately just spend an hour. I barely even ask questions to the patient, and we just spend the hour with them asking questions of me, and they really can just learn everything that they want about the disease. And I think patients feel and are more empowered after that visit, and I think that puts you in a better place for being more comfortable during the years you might be watching and waiting, to feel like, I know what's happening with my disease, I know what specifically to watch out for. So if you can do that, I think that's good. I do think, though, that probably the most important time is when you're getting to the point you might need treatment. We have guidelines for when patients need treatment, but a key example that I often see is patients come to me and they say, my IgM reached 3,000. My oncologist told me I have to start treatment now. I saw a patient like this last week, and I said, I don't think so. I think actually it's going to be months or maybe years before you need treatment, because that one number, when you're otherwise fine, all of the rest of your blood counts look fine, does not mean you need treatment now. So I really think often that's kind of the more important time. But if you have the luxury and the ability to do it earlier just to get a sense of your disease and make you feel comfortable of what to be watching out for, I think that's also helpful.
So then,
Would you please use the microphone because we're recording for the
Oh.
videos and we need to pick it all up on that.
Sorry, and I should have repeated the questions. I didn't think about that.
since I started, so then, I think I know the answer, but in your opinion, is it best to tell your physician that you're going for a second opinion before you go? What I've been talking about, like,
I think it's okay to tell your physician you're going for a second opinion. I think that can help you understand your physician a little bit better and what their approach is going to be like. This is all just, again, my opinion, this part, but I think it's okay to say, I'm super happy to be working with you and I want to continue all of my care with you, but I just want to learn a little bit more. And you can even say, I don't want to take up too much of your time asking a million questions. I'm going to go, I can just go, learn everything I can about the disease, and I want to continue to follow up with you and see you, but just want to let you know I'm going to, learn as much as I can right now about the disease. I think it's okay to say that. You will get different reactions, I think, from different people, but in my opinion, that's okay.
I've got a question.
And then we'll come to you.
I've got a loud voice, they could probably pick it up anyway. So when you're dealing with a provider who's a good oncologist but not a specialist, may not be as knowledgeable about the most recent therapies and things like that, as opposed to people like us who come to a forum and are seeing the latest therapies, seeing the latest data. We know you guys are busy, you don't get a chance to always absorb everything as it's moving up. Is there a way to, without causing offense, steer, if you think your oncologist is headed down a treatment path that you disagree with based on the data you're getting, how do you go about presenting that data to them without coming across as, oh, this is another internet expert that get on my hair?
I think sometimes I do this in my personal life, so again, just an opinion. I sometimes phrase things as a question rather than telling someone something outright, and I think that maybe is taken better, and even probably personally for me, an appointment, if a patient says, oh, what about this? I heard about this thing. Have you heard about it? Or do you know anything about it? I think it's new, even though it might not be quite as new, and you already know more about it maybe than your physician, but I think sometimes just phrasing it in a little bit of a different way might be helpful. And that happens to me in clinic. Patients ask me questions and I think, I didn't even think of that, And so I think maybe just, for those people who might take offense to it, maybe just phrasing it as a question or something that you're thinking about or that you maybe just heard about or might be new, and see what their thoughts are on it. Because sometimes it might just jog their memory. Oh, I heard about that, but I have so many other cancers I'm treating, it's hard for me to keep track of it. And maybe they'll say, oh, I'll look into that, or that's a good thought, I should consider it. So.
Further to that question, I know for me what worked is have the actual, like the research paper or whatever, the details of it, and say, like referring to that ahead of time. And the resident comes in first, takes my piece of paper with all my, questions and they go and do something, and then the doctor comes back.
Yeah.
So that's just maybe a little practical tip too, and actually not just like, oh, I heard that 4 rounds of the BNR should be good. I only want to do 4. Is to be like, well, there's this study that says, and what do you think? I think is really a good idea.
I think that's great advice actually too, because then maybe you're not catching your provider off guard where they feel like, oh, I don't know about that, and I'm going to be a little bit, on the defensive about it. So if you can, ahead of time just be like, oh, I saw this paper, does this mean anything for me? Or present it to the resident or the assistant that's working with the physician. That's, I think, a really great point.
One of the things I've run into is the doctors, the other doctors that you mentioned, like cardiologists, et cetera, being referred to them, and how many times I've heard them say, I remember reading about this disease when I was in med school, but you're my first patient I've ever seen. How important is it to educate those doctors about WM? What do they need to know about WM if they are looking at me, for a cardiology problem or ophthalmologist or whatever?
Yeah, and I think that's a great point, because as oncologists, this is a rare disease, but as a specialist in other things, it's even more rare for them. And so I think it's really important for you to bring up any knowledge that you have or present papers or information that you have. And I think that's another reason why it's important to seek out a specialist, is because the more patients that providers see with Waldenstrom's, the more they'll think about it, and and it will help the next patient that comes along with the same thing. So I think it's hard to know exactly what to take to them exactly and what to provide to each specialist, but I think whatever knowledge you have, I think, they would, if they have no experience, would be open to hearing what you have to say, or it certainly, again, helps the next patients if they learn more and more about it.
Having been at this for 30 years, I retired my first oncologist. We kind of muddled through, and he basically said he had a few patients, and we knew that all along. And got through the initial treatment. Then I had some 10 years. Then 10 years later, with when I needed treatment again, I kind of mentioned my association with the IWMF and with my knowledge of the Rituxan and my knowledge of Dr. Treon, and at that year, that was kind of the thing to do. And so then I was treated with Rituxan. So then we made it all the way to the 25-year retirement age. So I just picked they said, well, you need to pick a new oncologist from this group. So I picked one. I picked a woman, so And my initial meet and greet, I said to her, here it is. I said, I'm probably going to need treatment again, so I am going to go up to Dana-Farber in Boston to see Dr. Castillo. And how do you feel about that? Are you okay with that? And she said, oh, sure, yeah, fine. Mm-hmm. So we've been happy and getting along. I had my third treatment, and we're good.
Perfect. Yeah, I think that sounds like a good opening, is that you kind of, see how many, are they willing to work with other people or to learn. And I think, I will throw this out there just so you all know, often patients can't travel to get another opinion. But I initially came over to Dana-Farber because I knew of Dr. Treon and Dr. Castillo, who are wonderful, open people. And as a team, as a Waldenstrom's team at Dana-Farber, and I'm sure this is true for many other institutions, we always are open to hearing from other providers. So, our email addresses are widely available to everyone, and we often just have providers who, a patient can't come visit, but the provider just emails and says, here's a case I want to talk about, and we can correspond about it. We have our weekly Waldenstrom's meeting where providers from around the country, present cases to us that might be challenging. And so, the other thing, if patients don't have the ability to travel or that sort of thing, always, I'm throwing this out there, and Dr. Castillo and Dr. Treon, I think, would agree. We're always open to hearing from your local providers if you just want to give our information. And I'm sure this is true for many other specialists around the country and around the world as well, but it's a resource that's available.
Thank you. I'm curious, what is a reasonable expectation as a patient when we have unrelated issues to Waldenstrom's with our oncologist, but so for example, I was playing pickleball last year and my knee flared up with some, and I made aware the specialist that I went to for that, I get it that it's arthritis, but I also have Waldenstrom's, so does anything interact? And so ultimately, the medicine that he prescribed for me was not good to go with Imbruvica, and I didn't catch it until later. But I'm like, should I have been, and my oncologist knew that I was in this, seeing the clinic and stuff. So is it reasonable to expect that, that the oncologist would lead those kind of efforts? And had a couple other issues the same way, and it's like, kind of need like a coach, need somebody in charge of making sure these other doctors, it feels like, or is it just up to us and we shouldn't expect?
Yeah, I think as a provider, I would say it's hard, it's hard for me to know exactly what's happening with all of my patients, but I think as a patient, it's important and well within your right, and you should just, when I have any patients on BTK inhibitors, or venetoclax or any of the other ongoing therapies or even getting chemo, I ask my patients to just reach out if there's some medical issue going on. If they start a new medication, they'll just shoot me a message and say, I was just prescribed this for, a urinary tract infection. Is it okay to take it? And then I'll respond very quickly. I will say, as a hint maybe, for patients, when I get a short email or message like that, it's much easier to just respond. And so I think doing that helps your provider to be able to answer quickly, like, I was prescribed this medication, is it okay? And there can be a quick answer back. Sometimes they're very long messages. We can't answer them quickly, or there's time demands or that sort of thing, and it will slow it down a little. But succinct, quick messages, I think, is totally appropriate. The same thing is true for other medical issues. My patients often just alert me, I'm having this new back pain, and I'm going to see my primary. Often I say, okay, see your primary. If it's ongoing or continuing, let me know, because I want to work up how it might be related to Waldenström. So I think quick messages to update your provider, always warranted, always important, and well within your rights that you should be doing that to your oncologist, because it's hard, honestly, as a provider, for me to keep track of everything, and I don't want to miss something, so I like my patients to update me in that way.
Several times I've been sent to the ophthalmologist to check for bleeding in the back of my eyes. So I'm just wondering why ophthalmologist was not listed on one of your, I know you
good
can't
question,
list
yeah.
every specialist, but I just wondered, since I've been sent there several times, why an ophthalmologist wasn't listed.
Good question. It was not a thorough list. I think that's part of that was. I didn't list everyone. There are multiple other people that could have been included on there, but ophthalmologist is a very important part. I mean, routinely I ask my patients with Waldenström's to be seeing, especially those patients when they reach that, 3,000, where you start to be at risk for hyperviscosity or thickening of the blood. I have my patients being routinely seen by ophthalmology, so that is a very important specialty that should be involved with our patients for sure. Thank you for bringing that up.
Dermatologists, too.
Derm too, yes. Also not included on the list, but very important. Thank you.
I was just going to, on the topic of specialists for other conditions such as cardiologists, I don't know how common this is at other centers, but I know at Dana-Farber, they have specialists such as dermatologists that are familiar with WM and the impacts of BTK inhibitors. So I know a couple other folks up in the Boston area, they'll actually coordinate it so they come to see the doctor at Dana-Farber for their WM, and then the same day go see a dermatologist just to do their annual or biannual checkup. I would imagine there's other specialists in other areas that are also familiar at the better centers. So just food for thought there. I don't know how common it is. I would imagine Mayo and other centers probably have specialists that are actually very familiar with WM. So.
Yeah. That's an excellent point. I think that's very true. So if you're, as a new patient or as a follow-up patient, to be able to certainly ask that upon making an appointment, that it's not necessarily going to happen in a week or two. We can usually see patients on their own pretty quickly in our clinic, but if there are going to be other specialist appointments, it's not necessarily going to happen as quickly that we can line it up. But once in a while, I have a patient that, when they reach out, they say, I'm having this additional problem. Anyway, I can see neurology when I come to Boston, or that sort of thing. And we do our best to line that up for same days. So that's a great point to think about that if you're going to go to a larger center where they have additional specialists who might have familiarity with Waldenström's, to ask if you could be seen at the same time by those people. That's a great point.
Particularly because you're an amyloid specialist. I started, our oncologist, I don't have it, it's my husband. Our oncologist has been great and has worked with Dana-Farber very closely, so no issues there. But I started to suspect that some heart problems could be amyloid. And ask, and he said no. And so then his primary and his cardiologist, both, without my asking, suggested that that could be a problem. So I asked again. And this doctor who's been so open to, says, it's not amyloid. And it was right at the end of the, I mean, he was ready to leave, and I realized I needed to ask that. How did he, I mean, since then, we have had more testing, but one, should I have been so offended as I was? And two, how did he know that it is not amyloid? I mean, is there something?
Yeah, that's a good question. I think all of us probably, as patients and providers, should, we all have to, I think, try not to be offended, I think, when someone doesn't answer the question as we think they should, because it might be, a mistake. It might be, based on the knowledge that that person has or the experience they have. They might be giving you their best opinion, and they really feel comfortable saying those things. So I can't know in this specific circumstance, why they formed that opinion, but I think that's another example of where, asking questions, continuing to ask questions, that's really important as a patient, is to be your own advocate. And if you feel like something's a little bit off or you're wondering about something, I think it's totally appropriate to continue asking questions and asking of different people if you're not getting the answer that you have. I mean, I have had patients that they say, I'm having this side effect from a treatment, and I say, I haven't seen that. That's not really a common side effect. I don't think so. But then we keep going, and it turns out that they're a patient that has a rare side effect that I didn't expect. And my initial answer to them was, no, I don't think it's drug related. And then it ends up being that way. So I think as a patient, it's, important, as it sounds like you were doing, to continue asking other people and seeking answers. If you feel like in your gut something is not right, I think that continuing to ask is the right thing to do.
Hi, I'm going back to when you were saying when to get a second opinion. In my case, it was I didn't have the luxury when I was first diagnosed because I was so low. But I had heard of Dr. Treon and Dr. Castillo, but I was on ibrutinib through my doctors, and I was doing well. So when I decided to go see them in Boston was when my doctor wanted to change the treatment and take me off of ibrutinib and do something else. I thought, now I want to get that second opinion. And that turned out to be good. And it was a little awkward to go back because they disagreed with what the doctor wanted to do because I was doing so well. But they communicated, and I did have to go in and talk, but we worked it out. And now, once again, they want to change the treatment. But I think she knows. I said, I'm going to the conference this week. And she goes, okay, bring back the information and we'll talk about it. So
sometimes it might start off, maybe a little rocky, but sometimes you just have to figure out, everyone's personality is totally different too. So you might just have to forge ahead a little bit and, really just work out in your relationship with your provider the best way to communicate and ask questions and provide information. So.
Hello.
I recognize you.
I juggle in my mind when choice is too much. When a provider will give you a menu and say, okay, these are the pluses and minuses of each, choose. And I'm not sure I'm always competent. So for example, when I was given a choice of what I should begin my first treatment 2 years ago, I had a menu, Chinese menu, and because I distrust chemo, I rejected it out of hand. What I've heard here is that chemo plus rituximab can be a very good first approach, but I didn't know that. I just said chemo, forget it. So when is choice too much?
That's an excellent point, and I sometimes am guilty of that as a provider. Some patients really know what they want up front, or they have clear goals about their therapy, and I can help guide what to recommend. Sometimes patients don't have any preferences, and I provide a list of options, and then I see them looking at me like, give me a little bit more guidance. So I'm guilty of that as a provider. I think that's a good question. I think if you have this list of options, I think it's important to, I get this question a lot from patients, is if I was your relative, if I was your mother, if I was your father, what would you do? And honestly, that question does not offend me because it really makes me think about, what my top recommendation is for a person that I really care about. I think it's an appropriate question, to be honest with you. I think physicians will, if they're willing to answer in that place, will really give you what their gut opinion is. So I think that's an appropriate question, which might help narrow things down. I think sometimes when patients come to me with something and they just say, I don't want chemo, I have a family member with a bad experience with it. If it's not really my top choice anyway, I'll just go with that and not pull it back in to try to convince them that it's okay, even if it's not, if it's something that they have if they're not inclined to go with it anyway. Yeah, I think that's it. Because sometimes with Waldenstrom's there are so many excellent options. I think we are in danger of doing that. But that always helps me narrow it down, though, if a patient asks, so if I was your family member, what would you recommend? So I think that's an okay question to ask. That's just my opinion again, but it helps me to narrow it down for patients sometimes.
Hi, Dr. Sarosiek. Thanks for being here.
Of course.
In a patient who has a hemoglobin of 10 or less and feels okay or even good, isn't it detrimental to the cardiovascular system not to treat?
Not necessarily. It really does depend on the patient, to be honest with you. Some patients have much better cardiovascular reserve. Some patients have lower, and so the threshold for treatment is different per patient. I think in general, there's been a lot of research done even of when to transfuse patients, like when they get into this area where it might be too much stress or put patients at danger. And that level is actually much lower than 10. It's closer to 7 in some cases and even 8. So I think it's certainly individual for a patient, but hopefully with the knowledge your provider has about you as an individual, they can say if they think that that's a level that's harmful for you.
Would you caution them to, for example, not run a marathon?
Good question. I always tell my patients, and again, this is not specific medical advice for anyone, but a common line I find myself saying to patients is that they can be active to the point that they know that they're safe. So I don't want them pushing themselves where they are feeling worse than they should when they're exercising. They're getting lightheaded, chest pain, that sort of thing. But staying active is always important. But it really depends on the individual. I mean, we have some patients that are newly diagnosed that have been running marathons for years, and when they come to see us, their hemoglobin is 7. And they were doing it and they were fine, and their hemoglobin, I think, was low for years. So it really does depend on the individual patient and what their reserves are. So
Thank you.
But not across the board, not dangerous at less than 10, I would say. Yes.
One more question. So this new mutation that we learned about yesterday, the TP53, how do we do, if a lab can identify the CXCR4 and MYD53, do they know how to look for that mutation as well? Or, I mean, can we assume that, or?
Yeah, so it really depends on what test is sent, to be honest with you, from the bone marrow. A lot of places now are sending something called a next generation sequencing panel on bone marrows, and that panel will include TP53 or related mutations. And so if you have the full panel sent, if you're a provider, there are also specific tests just for mid-88 or just for specific things that might not be testing for that. But often, a lot of places now are using next generation sequencing panels, which include that mutation. So it's a question of what's sent. So it might not be sent unless your doctor asks for it, but if they use that full panel, it would be included.
How do we respectfully lodge a concern with a medical system, to make ourselves heard if we haven't had success with the problem with the doctor?
Oh, that's a great question. I think it's obviously going to be institution dependent. If it's a larger, I think honestly, if you're comfortable, first place is to talk to your provider and raise your concerns. A lot of the larger institutions and hospitals have patient family relation services, where essentially they are, a window for you to talk about your concerns, and then they will approach the providers for you. So if it's I think in individual practices, that might be something different, obviously, if there, are some physicians that work together and there's no one above them, like the patient family services, that I think can be a little bit more challenging maybe in a private practice. But at larger institutions and hospitals, they have patient family relations, I would say, at the vast majority of them, and that could be a resort or an option if talking with your provider isn't helpful. Sometimes there are, kind of ways around it. If you bring up a concern, even, if there's, another provider that's involved with your care, or nurse, or nurse practitioner, or physician assistant, if you have a specific concern and you say, oh yeah, I felt like I needed to be able to ask more questions yesterday, but I couldn't, sometimes that the person in the middle is able to help relay your concerns to the provider. Maybe they would take it a little bit better from someone else that they work with, but I think those are kind of the options, I think,
It
from my
can be
knowledge.
awkward.
If you have been seen at a center of excellence for your second opinion, do you have to have a local oncologist?
It really depends. I think it really depends on the situation. I think many of, and I think that I, in my practice, have a lot of different things. I have some patients who, see me once a year and follow with their local oncologist in between. I have patients who travel to see me and don't have a local oncologist, especially those patients that are on stable therapy for months and years, and there's nothing active going on. I think that many of my patients don't have a local oncologist. I think certainly if you're someone who's had a lot of complications or ongoing therapy, and you'll need interventions locally, it would be important to have someone. I think it depends a little bit on where you are in your care.
All right, thank you.
Other questions? Okay, I think we have just a couple minutes, and I think I pretty much finished up our slides, but I'm hoping that all of you can find a provider that's willing to listen, converse, and learn from you and from others. I think that's really crucial. Hopefully you can find a provider that will present information in a way that's understandable to you, and certainly within reason, and very important as a patient, if your physician or provider is just rambling on, which maybe I've done during this meeting, I don't know, rambling on a way that's not comprehensible to you, or that you need it put, in a more succinct manner or in ways that you understand, definitely ask and say, okay, so what are the key things I should know about what you just said? I think that's important. I really think it's crucial as physicians. We don't know everything. We'll never know everything. And we always have to be open to collaborating with others. I have patients that see us at Dana-Farber and see someone at Mayo Clinic and see someone at Stanford and see lots of experts. They see multiple different people, and I think that's okay. I'm always learning something from their opinions that they get from other places. So if you're someone who feels like that's something you need to do, I'm not saying that's right for everyone, but I think I can always learn too. So always, I think if you can find a physician who is willing to do these things, that's wonderful. And there are always resources available through IWMF and other providers around the country and around the world that are willing to help you if you need it. So thank you all for your attention. Really appreciate it.
I have one more question.
Oh, yes.
Yesterday, as it was pointed out, I think it's an important question for us to ask our oncologists if they received that mailing.
Oh.
I intend to ask mine, my local one, and to see if they got it, see if it went to the wastebasket, or to see if...
They took a look at it.
I thought of one too. In a large institutional setting, I was told that if you need a second opinion for something, no matter what, you should go outside that institution because they tend to defend each other if doctors working in the same large institution.
I think often, I think maybe, in my mind, maybe not that's the reason, but I think often we've already collaborated maybe. I think people who work and train in the same institution often learn things the same way. And we collaborate with each other. When I see new patients, I talk with Dr. Castillo and Dr. Trion, with our team about the patient. And so seeing another person in our Waldenstrom Center, they would already know the opinion that you received. So I think that's a benefit to going elsewhere, is you do get a fresh look at things, and maybe they haven't already talked to the same providers about the information for your case already.
Thank you.
All right. Thank you so much. And the other thing too is, one thing you can do is take some of those brochures that are at the front desk and take them to your oncologist. The patient's perspective. I see mine on Tuesday, and I figure I'm going to give a half a dozen of them to her so she can hand them out to newly diagnosed. So the more we can do locally to educate our own oncologists, go for it. That's what we're here for.
Perfect. Thank you all.